Welcome to Operations and Incident Management for Pediatric Surge. I'm Mark Dascalos. I'm the System Director for Trauma for the Fairview Healthcare System. This module is designed to help healthcare providers think of the special circumstances involved with caring for a pediatric patient. More specifically, in regards to operationalizing of surge plans, activation of incident command, resources available, and the utilization of the Family Assistance Center. Upon completion of this module, participants are encouraged to examine their facility's plans and identify any gaps or areas where considerations need to be made with regards to caring for pediatric patients. As participants, you will be introduced to the concepts of facility-based incident command and will understand how to incorporate those concepts into your facility. We will discuss the resources available to support your facility during a pediatric surge response, as well as the role and responsibility of the Family Assistance Center. At the end of the presentation, you are encouraged to take a critical look at your current plans and identify if there are any gaps or areas for improvement needed to facilitate a better response during a pediatric surge. Similar to our patients, incident command can be as simple or as complex as the situation requires. Incident command is flexible and scalable. You do not need to have a fully staffed incident command with every incident or event. It is important to start simple and expand as necessary to fulfill the needs of the situation. Regardless of size, there is always an incident commander. This individual is responsible for identifying what actions need to be taken to accomplish the goal of saving lives. The incident commander will request individuals to fill the other roles within the command structure as necessary. Incidents typically do not always occur during the day. The incident commander may be the charge nurse or the supervisor on duty. They must be prepared and empowered to make critical decisions about the response until someone else who is more qualified comes to take over. The basic organization chart is divided into two sections, the command section and general staff. It is designed in this way so that each role on the chart is responsible for no more than 3 to 5 individuals. The more in-depth organization chart displayed further breaks down the sections into functional units and branches. As said earlier, all these positions do not need to be filled. Individuals who can be considered to fulfill roles within the command structure or the general staff are facility executives, nurse leaders, supervisors, maintenance plant services, EMS leaders, or risk and safety leaders. The general staff is composed of 4 basic sections. The operations sections are the doers. They are the boots on the ground workers, providing direct patient care, working in the lab, pharmacy, and radiology. Operations also includes facility security. They are doing what they do every day. The planning section are the thinkers. They are the ones that need to think ahead to what needs to happen next. They collect data and analyze the situation to identify what needs to occur to successfully respond to the event. The logistics section are the getters. They are responsible for getting the stuff that the operations section needs to successfully do their work. They are responsible for ensuring that everyone has the resources needed. It includes getting staff, supplies, and equipment. They arrange for transportation assets. The finance administration section are the payers. They work closely with the logistics section to pay for the resources, and they track the expenses as they occur. Having a tight or narrow span of control allows for more control and increased awareness of the situation. Supervising 3 to 7 individuals ensures each position only has one person above them to report to and or to take orders from. This leads to increased efficiency as it allows for simple decisions to be made at the lower level and allows leaders to focus on the bigger issues. Incidents are not limited to 9 to 5, Monday through Friday, when facilities have access to increased staff and resources. It is essential that processes are in place that empower your staff to make critical decisions and activate the incident command. Determining trigger points for staff to use will assist in this decision making. Staff need to know who to call and when to call them in. So how many patients do you need before incident command should be activated? This is a facility level decision that should be discussed before events occur. Typically, when there are more patients than caregivers can safely take care of, is a time and a good indication that help is needed. When EMS reports that there is a situation where there are multiple patients inbound, or you hear that there is a mass casualty situation, do you wait for the patients to arrive at your door before calling for help? When you rely primarily on on-call staff who are responding from home to backfill your current staffing, the delay in activation and calling them in can be critical to the ability to respond and care for your patients. Activating incident command may seem complex. However, when utilized objectives are set, resources are made available to meet the objectives. Communication pathways are clearly defined, and things generally run smoother. If facilities were to practice activation of incident command, they would be more familiar with the roles and responsibilities so that when those big emergent incidents occur, they are better prepared and can smoothly transition into their roles. Incident command can be used for planned events as well as some minor unplanned events. If the facility's CT scanner is down for maintenance, activate your incident command and assign the roles to determine how they are going to manage stroke patients, where to send patients while the equipment is down, and how this downtime would affect the emergency department. If the phone system goes down, this affects multiple departments. Activating incident command allows for decisions to be made to adapt and communicate without phones. There are many daily incidents that can help you exercise your command structure. Recognizing there is a situation requiring more resources than what the facility can handle is when you pull the trigger and initiate the incident command system and call in resources to help. While care is being provided, someone needs to step back and organize the next steps involved. When dealing with any surge event, and more specifically a pediatric surge event, it is essential additional resources are accessed. For example, you may need a behavioral health unit or additional help in establishing a family assistance center. Remember, you have resources within your own staff. Assessing your staff prior to emergencies to identify individuals who may have leadership ability, community resource knowledge, can speak sign language or another language, have military experience, are volunteer firefighters or first responders. These individuals are essential when responding to a surge event. So what happens if you call people in and they are not needed? This is a great opportunity to evaluate your facility's response. You will want to evaluate the response time and identify if there were any gaps in the recall procedure. You will quickly learn who you can rely on to make it into the facility quickly. Record the response and utilize it as a real event training so that you can identify lessons learned and any gaps or areas for improvement. Take credit for that work and discuss this with your facility's emergency management team. We are going to have you think about your own facility and its plans as we discuss this scenario. Are there areas that concern you or areas that you do not know what the plan is or where the plan is located? Use these lessons as a follow-up to this module. We recognize that your facility may be larger. However, for this scenario, imagine you're working at a critical access hospital that has a 5-bed emergency department. 3 of those beds are currently filled with patients. You're on generator power due to a power failure. You have been notified by EMS that there has been a rollover accident with 2 critical victims that are being transported to your hospital. Now, this scenario is not very far-fetched. This can and does occur on a daily basis. Let's think about the resources you have in your building at the time of this incident. You have 3 nursing staff members working. 1 RN in the ER caring for those 3 patients, and 2 RNs on the patient floor caring for 8 low to medium care patients admitted on the floor. 2 paramedics are out at the accident scene. You have an ER physician who happens to be a locum, an interim physician. Your facility has an off-site nursing supervisor who is currently covering another hospital. Think about this scenario and apply it to your facility. Who can activate your incident command plan and who can call in additional staff? Who would be the incident commander until more help arrives? Is that individual trained in incident command and do they know the resources needed? Does your facility utilize an automatic callback system or a phone tree? Who is going to make the calls? If your facility has an automated callback system, who could trigger the callback? Do they have capability 24/7 to create a callback? If it is a phone tree that is used, where is it at? Okay, so now you have assessed your current staffing. You have a radiology supervisor and a maintenance staff person who live within 2 miles and can be at the hospital in about 20 minutes. Your manager lives 40 miles away and will come in if necessary. The on-call manager thinks that you can handle the situation with your current resources. Does your facility have security? Is there a plan to incorporate security during a surge event? Are you relying on local law enforcement, the county sheriff, or fire department to provide support at your facility? If yes, it is important to know that these resources may already be unavailable because they are currently at the scene response. How about volunteers? Do your surge plans include utilizing facility volunteers to assist? Have they been trained, and do they know their role? Is there the capability to lock down your patient care areas, to limit access? How many access points are there to your building? How do you secure these access points? If you do not have a central locking station to secure your patient care areas, how many individuals will it take to go around and lock those areas? Are your staff and volunteers trained in incident response, crowd management, or de-escalation techniques? Volunteers are an invaluable asset to your facility during day-to-day operations. It is important to understand how your facility uses volunteers routinely so that during emergent events you are able to tap that resource. Are volunteers trained in emergency procedures, and do they have a role in your facility's plan for responding to a surge event? If not, can your plans be revised to include using volunteers? As we go further in discussion of this scenario, you will soon recognize that there's always something to be done. Does your facility vet your volunteers through an application process that includes security checks? Now let's go back to the scenario. You have now found out that the wounded include 4 pediatric patients. How about 8 pediatric patients? Does knowing that there are pediatric patients involved change the decision process? Do you want more resources? Are the plans that you have now applicable when caring for multiple pediatric patients? What additional resources may be needed? Do you know where your pediatric supplies and equipment are located, and do you have access to them? A pediatric patient requires additional resources to care for them. Does your facility have pediatric kits? If not, consider creating kits that allow for easy access. Things like IV supplies, C-collars, medication tables, diapers, cribs, formula and bottles, and specific resuscitation equipment. Do you have items on hand that can be useful for distracting or entertaining the pediatric patients? Stuffed animals, books, crayons, and coloring books. When dealing with pediatric patients, you often have to deal with unaccompanied minors. Does your facility have a plan in place that identifies how to care for an unaccompanied minor? What is the process used when admitting an unaccompanied minor? How about discharging? Where do they go and who is responsible for them? Do you have access to the forms that are required for working with these minors? Is there a process in place or a place to hold minors waiting for pickup by their guardian? Is that place secure? Do you have a plan to shelter your patients? Remember, you should not shelter an unaccompanied minor with an unvetted adult. Are there any specific things to be concerned about with regards to HIPAA? The point being made by all these questions is that the pediatric patient requires special considerations. A plan that focuses more on the adult population will be inadequate when working with pediatrics. The care of a pediatric patient can require specialized care providers, such as a pediatrician, pediatric surgeon, burn physician, trauma physician, mental and behavioral health providers. Does your facility have access to these specialists? If not, do they utilize telemedicine to connect with specialists? Are there lists of contacts that can be used during a pediatric surge event? Are there agreements with agencies that can provide support? When caring for a pediatric patient, you are also caring for the patient's family. In a surge event, you will be dealing with distraught parents and extended family members. The facility can quickly be overcome with individuals requesting information and demanding answers. Does your facility have an area that is designated as a family resource or a reunification center? Is this area secure and located away from your patient treatment areas? Is there an area where an individual family members can be taken for consultation with physicians? How many visitors are allowed in your ED treatment areas? Is there a policy that supports that? How about legal issues? Parents are divorced, perhaps restraining orders, non-custodial adult only available. Who can the child be discharged to? Are there policies on how to deal with these issues? Who can be a resource to be used in this area? Do you have 24/7 access to legal counsel? The Family Assistance Center is a registration center. Members are registered and provided with a wristband. The center uses sign-in sheets to facilitate tracking of visitors as well as any unaccompanied minors. It is a source for information sharing. Fact sheets, visitation rules, etc. are handed out. It can be a reunification center to aid the local law enforcement and emergency management in identifying where the pediatric patients are located. It is often used to provide family support services such as social services, clergy, school liaison, etc. The Family Assistance Center must be closely monitored to ensure that media and non-essential individuals do not have access. Unaccompanied minors create a need for specific considerations. Processes must be in place in the Family Assistance Center to make sure that there is a safe place for unaccompanied minors. Social services need to be involved, and there needs to be a process in place on how to notify social services for assistance in determining appropriate legal guardianship. During large events, healthcare facilities are encouraged to coordinate response efforts with their local emergency management. That could be law enforcement, fire, city or county government. A coordinated family reunification center or resource center can be created. During events that could require that the Family Assistance Center is open for a long term, the facility needs to consider cultural needs of the patient and their family dietary needs. Continued space for family members of admitted patients, increased visitations from extended family and friends, and possibly requests for visitation from pets. Having policies in place can help alleviate increased stress and anxiety for both staff and visitors. The Los Angeles County EMS and Department of Health Services have created a Family Information Center planning guide for healthcare. This toolkit provides checklists, job action sheets, processes, and plans for setting up a Family Information Center or Family Assistance Center. You can access this document through the California Hospital Preparedness website at calhospitalprepare.org and search for the Family Information Center. Mentioned earlier, when dealing with unplanned emergency events, it is inevitable that the media will be knocking at the door requesting information. They may even attempt to gain access to patient care areas and the Family Assistance Center. Facilities are highly encouraged to have a trained public information officer that can coordinate communications during incidents. This person will monitor social media as well as conventional media outlets. The public information officer will work with your facility's incident commander, as well as the local emergency manager and other responding agencies to ensure that messaging is accurate, timely, and consistent. Recognizing that the media will not go away without answers, the hospital should designate an area for the media to have access to the internet, phones, and receive briefings on a regular basis. This area should be away from all patient care areas, the facility's command center, and the Family Assistance Center. With any incident, the incident command team should start planning for demobilization as soon as the event starts. It is important that the planning section work with the incident commander to determine demobilization triggers. These triggers are subjective, and it may be necessary to change them. The planning team should create a demobilization checklist. The public information officer should prepare messaging that shares the demobilization process with those in the Family Assistance Center as well as those within the media. As soon as the demobilization is completed, it is imperative that a debriefing be conducted to identify and document lessons learned. To summarize, healthcare facilities that pre-plan, train, and exercise for events will have a better response. Facilities that incorporate the incident command process into their day-to-day operations are more successful when implementing incident command during emergencies. Facilities have more resources than they may think. It is important to assess your current staffing availability to recognize that there may be individuals that have special skill sets that can be used during emergencies. Beyond that, facilities also need to know where outside resources are available and how to access them. Facility plans need to be reviewed to ensure that they take into consideration special populations, such as the pediatric patient. In any event, communications with staff, with patients and their families, and with the community is essential for a successful response. Facilities that have a predetermined, trained public information officer will be much better at handling communication needs in a response. And finally, remember, when you have a pediatric patient, you will be dealing with more than just the patient. There needs to be a process in place that provides for families, extended families, and friends. If there is not already a Family Assistance Center plan, consider creating a plan that can be implemented for emergent situations. Thank you for watching this presentation. We encourage you to explore the Pediatric Surge website for more information on topics pertinent to pediatric surge in the state of Minnesota.